This is the part B of lecture 6 in endocrinology. Remember, the first part we are looking at bone physiology and also the metabolism of calcium and phosphates. Here we are going to concentrate much on the parathyroid hormones and calcium metabolism. Of course, towards the end we are also going to discuss vitamin D and its function when it comes to calcium metabolism. So this is what we are going to discuss. The parathyroid hormone, they are being produced by the parathyroid gland that are located on the caudal aspect or the posterior aspect of the thyroid gland. So behind the thyroid gland, that's where you find two pairs of parathyroid glands. So you can see this is the posterior aspect or the thymus. You can see the two pairs of parathyroid glands that are embedded within the thyroid tissue. So there are two pairs of parathyroid glands. You have two parathyroid glands that are on the superior aspect and two on the inferior aspect of the thyroid gland, but behind the thyroid gland. So you can appreciate the anatomical location of the parathyroid gland. If you take a cross-section of parathyroid gland, you appreciate hormones that are being produced by mainly the chief cells. So you can see a lot of these chief cells that are shown here. They produce a lot of parathyroid hormone. So they are called chief cells because they are the ones that are producing parathyroid hormone. Then we have another type of cells, they are oxphill cells, of which they also produce some other substances whose function is not well known. So you have these oxphill cells. Then the blood supply, where you find red blood cells within the capillaries here. So you need to have blood supply to the parathyroid glands as well to produce and also to secrete the hormones into the cardiovascular system for the transportation of parathyroid hormone once it has been produced. By now you understand to say the parathyroid hormone is going to activate the osteoblasts by attaching to osteoblasts. They have receptors for parathyroid hormone, then that will activate the osteoblast to produce cytokines, the osteoprotegerin ligand that can go and bind to pre-osteoclasts. Then they'll be activated, they'll undergo differentiation, they'll become mature osteoclasts. Then they are going to develop a ruffled border where there will be secretion of enzymes from the lysosomes and also secretion of acids. The acids will cause dissolution of the minerals, and then the enzymes will cause digestion of the ground substance and the collagen fibers. That will bring about bone resorption to mobilize minerals like calcium and phosphates from the bone tissue that will now be released to the extracellular fluid compartment to control the concentration of calcium. But remember, there is another enzyme, another hormone that is antagonistic to parathyroid hormone is called calcitonin. That calcitonin hormone is released when there is a high concentration of calcium in the extracellular fluid compartment. If there is a hypercalcemia, it will be secreted. Then it will try to inhibit bone resorption and also inhibit reabsorption of calcium from the kidneys. The levels of calcium will start reducing. So it has got the opposite function to that of parathyroid hormone. But now we are discussing the parathyroid hormone in details. The control of parathyroid secretion by calcium ion concentration. Remember, we had mechanism by which the hormones can be secreted, of which we said some of it is humoral, whereby they are responding to the concentration of ions or the concentration of nutrients in the blood. Calcitonin and parathyroid hormone, they were responding to the concentration of calcium. If there is low calcium concentration in the extracellular fluid compartment, then parathyroid hormone will be released by the parathyroid gland from the chief cells that are producing the parathyroid hormone. Decrease in calcium ion concentration causes an increase in parathyroid secretion. This may also lead to hypertrophy of the gland. If there is less levels of calcium, the chief cells will be overstimulated to release a lot of parathyroid hormone. So if you have a continuous low levels of calcium or hypocalcemia, it can bring about hypertrophy of the gland on itself, because now these cells will be overstimulated to produce parathyroid hormone. So if they are overstimulated, then they are going to increase in size. That will bring about hypertrophy of the parathyroid gland. So just know that if you have decrease in calcium, iron concentration can cause an increase in parathyroid hormone, and this can also lead to hypertrophy of the glands. Increase in calcium ion concentration causes a decrease in parathyroid secretion, so it's the opposite. So if you have an increase in calcium concentration, hypercalcemia, it will inhibit the release of parathyroid hormone, and also the size of the parathyroid gland can decrease in size. That will bring about atrophy of the parathyroid gland, so they may reduce in size because of that. Changes in extracellular fluid calcium ion concentration are detected by calcium sensing receptors in the parathyroid cell membrane. In the parathyroid cell membrane, we have calcium sensing receptors or calcium sensitive receptors. These are receptors that are sensing, or they are sensitive to calcium. They are G protein coupled receptors. Once they are activated, they will cause an increase in the production of parathyroid hormone, or they can regulate the secretion of parathyroid hormone, of which the mechanism I'll explain. The calcium sensing receptors is a G protein coupled receptor, like I've already explained. Increased extracellular calcium is going to activate phospholipase C, because they are G protein coupled receptors. If you have an increase in the extracellular calcium levels, those calcium will be now activating the calcium sensitive receptors, or the calcium sensing receptors, which are G protein coupled receptors, and then they will activate the G protein that will dissociate. The alpha protein subunit will dissociate from the beta gamma protein subunit, and you know to say that the beta gamma protein subunit can go and activate the phospholipase C. That will bring about an increase in the intracellular inositol triphosphate. The IP3 is going to increase in diacylglycerol molecule. The IP3 is going to mobilize calcium from the endoplasmic reticulum. So this is going to stimulate the release of calcium from the intracellular stores, which is the endoplasmic reticulum. Then in turn, an increase in the intracellular calcium will inhibit the secretion of the parathyroid hormone. So you don't need to get confused here. This is one of the rare situations whereby calcium inside the cell is inhibiting exocytosis. Because in many mechanisms, you realize to say an increase in the intracellular calcium is going to bring about exocytosis of hormones, neurotransmitters. But here it's the opposite. These are the chief cells, they are special cells. So the increase in the intracellular calcium, instead of enhancing exocytosis of the parathyroid hormone, is going to reduce the exocytosis and also the production of parathyroid hormone. So it means if you have an increase in the extracellular calcium, the calcium outside the cells, you have hypercalcemia. It's going to activate the G protein coupled receptors that will activate the G protein. Then the G protein will activate phospholipase C, that will increase the production of inositol triphosphate that will go to the intracellular stores, the endoplasmic reticulum, to mobilize more calcium from the endoplasmic reticulum. That calcium now is going to inhibit the secretion and the production of parathyroid hormone from the chief cells within the parathyroid glands. So this is the mechanism. There will be less release of parathyroid hormone. If you have less parathyroid hormone, there is less bone resorption, there is less absorption of calcium from the GIT, there will be less reabsorption of calcium in the kidneys. So that in itself, you are going to have a decrease in calcium levels, because much of the calcium will be excreted in the urine. So you find that that will regulate the concentration of calcium. Decreased extracellular fluid calcium ion concentration inhibits these pathways and stimulates parathyroid hormone. So the opposite now will happen. If there is a hypocalcemia, it means that the calcium sensing receptors or the calcium sensitive receptors won't be sensing the presence of calcium. then there will be less phospholipase C that will be activated. There will be less inositotriphosphate. There will be less mobilization of calcium from the endoplasmic reticulum. Less calcium, that will encourage now exocytosis of parathyroid hormone. The parathyroid hormone will go and mobilize calcium from the bone to cause bone resorption. You are digesting the bone tissue to mobilize calcium from the bone. Then it will go to the intestines to increase absorption of calcium from the intestine, and also via activation of vitamin D that can also increase absorption of calcium from the intestine. Then it will go and enhance reabsorption of calcium from the kidney nephron. So the overall result, you have an increase in the calcium levels. Okay. The parathyroid hormone and calcium metabolism, we proceed. The parathyroid hormone provides mechanism for controlling extracellular calcium and phosphate concentration by regulating intestinal absorption, renal excretion, and exchange between the extracellular fluid and the bone of these ions. So it's going to balance up the interchange of calcium. There are 4 parathyroid glands in humans. They are located immediately behind the thyroid gland, one behind each of the upper and each of the lower poles of the thyroid gland, of which I mentioned the location of the 4 parathyroid glands, the 2 pairs of parathyroid glands in a human body. Excess activity of parathyroid gland will cause rapid resorption of calcium salts from the bones. If you have excessive amount of parathyroid gland, it means they are producing a lot of parathyroid hormone that will cause excessive resorption from the bone. So you are mobilizing more calcium from the bone, so you have an increase in calcium levels with resultant hypercalcemia in the extracellular fluid. So you know to say if you have bone resorption which is increased, you are mobilizing more calcium that will result into hypercalcemia in the extracellular fluid. And you know to say hypercalcemia can cause depression of the nervous tissue. That will bring about muscle weaknesses as clinical signs or symptoms of excessive parathyroid gland that is producing excessive amount of parathyroid hormone. The hypofunction of parathyroid hormone is the opposite now. The thyroid gland, they are not producing a lot of parathyroid hormone. That will bring about hypocalcemia because you're not absorbing much of the calcium from the GIT, you're not mobilizing more calcium from the bone, you are not reabsorbing much of the calcium from the kidneys. So the overall result will be excreting a lot of calcium that will bring about hypocalcemia, and often with the resultant muscle tetany. There is a hyperexcitability of the nervous tissue, spontaneous firing of action potentials that will overstimulate the muscles. The muscles will be involuntary muscle contraction. And of course, that can also result into muscle weakness with time. The physiological functions of parathyroid hormones and calcium homeostasis, the control of this calcium. Parathyroid hormone, of course, they are there to increase the serum calcium level and to decrease the phosphates levels. This is a major function of parathyroid hormone. It's going to increase the serum calcium level, then it will decrease the phosphates levels. How? It's because the parathyroid hormone is increasing absorption of calcium from the GIT. The absorption of calcium and phosphates from the GIT is enhanced or increased. It's also going to increase bone resorption. You're mobilizing calcium and phosphates from the bone. But when it comes to the kidneys, the parathyroid hormone is increasing the reabsorption of calcium from the kidneys. Then it's not enhancing the reabsorption of phosphates. So the overall result is the plasma level of phosphates is decreasing because much of the phosphates will be lost to the urine in as much as you are conserving the calcium, because calcium is being reabsorbed. There is much of calcium reabsorption as compared to the phosphates. So the phosphates levels in plasma will decrease because of that reason. So the overall results, you have an increase in serum calcium and a decrease in phosphates. Why? It's because increasing bone resorption. The parathyroid hormone is increasing bone resorption, which brings both calcium and phosphates from the bone minerals into the extracellular fluid compartment. You are mobilizing calcium and phosphates from the bones. At the same time, the same hormone is inhibiting renal phosphates reabsorption. It's going to inhibit the reabsorption of phosphates from the kidneys in the proximal convoluted tubule. If the reabsorption of phosphates is inhibited, you are excreting or you are losing much of the phosphates in the urine. At the same time, you are reabsorbing much of the calcium. So you realize to say that there will be an increase in renal calcium reabsorption in the distal tubule. In the distal tubule now, there is reabsorption of calcium, which also increases the serum calcium levels. Increasing intestinal calcium absorption indirectly by stimulating the production of 1,25-dihydrocholecalciferol, vitamin D, in the kidney. You will need the parathyroid hormone to convert 25-hydrocholecalciferol into 1,25-dihydrocholecalciferol, the active form of vitamin D. And it is this vitamin D that will go and enhance absorption of calcium. The vitamin D can activate the production of calbindin. These are proteins that are involved in absorption of calcium in the intestines. The mucosal cells of the intestines or the epithelium cells of the intestines, they can increase their absorption of calcium with the presence of vitamin D, the active form of vitamin D, which is 1,25-dihydrocholecalciferol. So you find that there is a lot of absorption of vitamin D in the intestines. But this active form, you will need parathyroid hormone that will also activate the conversion of vitamin D into its active form in the kidneys. Coming to vitamin D and its function, vitamin D is going to provide calcium and phosphates to extracellular fluid compartment for bone mineralization. Whatever calcium and phosphates that is being deposited on the bones, the vitamin D is required because it's the one that will provide the calcium and phosphates to the extracellular fluid compartment. It's activating absorption of calcium and phosphates in the GIT. It's also enhancing reabsorption of calcium and phosphates in the kidneys. It's also causing bone resorption to some extent. So you find that you have an increase in calcium and phosphates concentration in the extracellular fluid compartment that is required for bone mineralization. That's why for you to have strong bones, you need vitamin D. For you to have strong teeth, you also need vitamin D because that will bring about mineralization of the bone tissue, the deposition of salts or minerals into the bone tissue. In children, vitamin D deficiency causes rickets because now there is no tensile strength, there is no compressional strength. Then you find that the bone will start bending. Okay, the long bones, they can't bear your weight, so you find that they'll start bending. So you have rickets because you have less of vitamin D. If you have less of vitamin D, there will be less deposition of minerals on the bone. Then the strength of the bone will be very weak. Then they can start bending. They can't outstand your weight as you are growing up. In adults, vitamin D deficiency causes osteomalacia. The bones will become very weak and then you'll be prone to fractures. They can easily fracture because the bones are very weak. Because now you're an adult, you find that the bone can't necessarily bend, but it will become very weak and then it will be more prone to fractures. So especially our friends like the Indians, the Muslims in particular, you know, the Muslims, especially the ladies, they are always covering everywhere. They have that attire which they wear so that they don't expose their body to men, which is a good thing. They will just expose their eyes. They are covering with clothes which are black in color, so sometimes that can inhibit the sun. The sun doesn't really get to the skin, so there will be less activation of vitamin D. Then they will be prone to bone fractures, especially osteomalacia, because now they are not accessing enough vitamin D because they are not accessing enough sunlight that is required to convert certain forms of vitamin D. The vitamin D is going to increase both calcium and phosphates in the extracellular fluid for new bone to form, so for bone mineralization. Like I said, how does it do that? It's going to increase intestinal calcium absorption. The intestinal calcium absorption is increased, and also the intestinal phosphates absorption is increased under the influence of vitamin D. At the same time, it's going to increase renal reabsorption of both calcium and phosphates. This is opposing to that function of parathyroid hormone, because the parathyroid hormone, we said, is inhibiting the reabsorption of phosphates. But here, vitamin D is encouraging the reabsorption of both calcium and phosphates. So the overall result is that you have an increase in calcium and phosphate serum concentration because reabsorption in the kidneys is facilitated by vitamin D. The vitamin D, which is also called cholecalciferol, is formed in the skin as a result of irradiation of 7-dihydrocholecalciferol, a substance normally in the skin, by ultraviolet rays from the sun. So the ultraviolet rays from the sun are the ones that are going to activate the vitamin D that is under the skin. So under the skin you have cholecalciferol. So you need the ultraviolet rays to convert it into 7-dihydrocholecalciferol. The vitamin D compounds that we ingest in food are identical to the cholecalciferol formed in the skin, except for the substitution of one or more atoms that do not affect the function. So even the vitamin D that we ingest from the foodstuff that we are eating is basically the same vitamin D that is under the skin that will be worked on by the ultraviolet rays, but there are some minor differences in one or more atoms, but that do not really affect the function of this compound. The first step in the activation of cholecalciferol is to convert it into 25-hydrocholecalciferol in the liver. The cholecalciferol, it will be transported to the liver. In the liver, there are enzymes that will add the hydroxyl group to convert it into 25-hydrocholecalciferol. This is the first step in the activation of vitamin D. The 25-hydrocholecalciferol has a feedback inhibitory effect, which is important for two reasons. So you need to regulate the amount of vitamin D, the active form of vitamin D. Because the excessive amount of activation of vitamin D, you know the effect of vitamin D. You will have hypercalcemia, then you can also have hyperphosphatemia, meaning that you have an increase in calcium levels and also phosphate levels. So to inhibit that, you find that there is regulation. So the same 25-hydrocholecalciferol has the feedback inhibitory effect, which is important for two reasons. The first one, to prevent excessive action of vitamin D, because you don't want to activate much of this vitamin D, so it's regulated by negative feedback mechanism. Then it's also important to control the conversion of vitamin D3 to 25-hydrocholecalciferol. That will conserve the vitamin D stored in the liver for future use. So you don't want to use all the vitamin D, much of it will be stored within the liver for future use. So the 25-hydrocholecalciferol will inhibit the conversion of vitamin D3 into 25-hydrocholecalciferol. Once it is converted, it persists in the body for only a few weeks, whereas in the vitamin D form, it can be stored in the liver for many months. So you don't want much of this vitamin D to be converted into 25-hydrocholecalciferol because it will be used up very fast by the body itself. So some of it has to remain in the form of vitamin D so that it can be preserved for future use. The conversion of 25-hydrocholecalciferol to 1,25-dihydrocholecalciferol requires parathyroid hormone. The activation now of 25 into 1,25-dihydrocholecalciferol that takes place within the kidneys, it requires the presence of parathyroid hormone. The parathyroid hormone is the one that will be activating the enzyme that will add another hydroxyl group on carbon number 1, hence converting the 25 into 1,25 dihydrocholecalciferol. The plasma concentration of 1,25 dihydrocholecalciferol is inversely affected by the concentration of calcium in the plasma. The more calcium you have, the less the activation of 1,25 hydrocholecalciferol, which makes sense because if you still have a lot of this 125 hydrocholecalciferol, you'll be absorbing a lot of calcium from the GIT, you'll be mobilizing more calcium from the bone, you'll be reabsorbing much of the calcium from the kidneys. So you end up with the hypercalcemia. So the more the calcium you have, the less the 125 hydrocholecalciferol you are going to have. When the plasma calcium concentration is already too high, the formation of 1,25 hydrocholecalciferol is going to be depressed so that you don't have much of this active form of vitamin D3. Result decreases the absorption of calcium from the intestines, the bones, and the renal tubules, something that I've already explained. So the result is you have a decrease in absorption of calcium from the intestines, the resorption from the bones, and also reabsorption from the renal tubules is going to decrease. This is just a diagram that is explaining the conversion or the activation of vitamin D in the skin and all the way in the kidneys and their function. So you can see under the skin we have cholecalciferol, the vitamin D that will be worked on by the ultraviolet rays from the sun to convert it into 7-dihydrocholecalciferol. Then the 7-dihydrocholecalciferol will be transported to the liver, where it will be converted to 25 hydrocholecalciferol. The 25 hydrocholecalciferol, there are enzymes that are adding the hydroxyl group to convert it into 25 hydrocholecalciferol. The hydroxyl group is added to carbon number 25, hence the name 25 hydrocholecalciferol, which has got a negative feedback mechanism to inhibit more activation of cholesterol. So if you have more of 25 hydrocholecalciferol, this will inhibit the reactions that are producing the 25 hydrocholecalciferol, a negative feedback or negative inhibition. In the kidneys, you have enzymes that can add another hydroxyl group to the 25 hydrocholecalciferol on carbon number 1, converting it to 1,25 hydrocholecalciferol. But these enzymes that are adding the hydroxyl group, they need the presence of parathyroid hormone. Without the parathyroid hormone, they can't do that. So they are regulated by parathyroid hormone. The parathyroid hormone is the one that is going to activate those enzymes. Then they'll be able to convert 25 into 1,25 dihydrocholecalciferol. This 1,25 dihydrocholecalciferol is the active form of vitamin D3. It will be transported to different organs, so it will go to the intestines, it will go to the kidneys. In the intestines, you know to say the 125 dihydrocholecalciferol is going to increase the calcium-binding protein. So you have calcium binding protein, calbinding, that will be produced. You have calcium stimulated ATPase. These are the enzymes that are involved in pumping of calcium. Then you have alkaline phosphatase that are also involved in absorption of phosphates. So both calcium and phosphates will be absorbed in the intestine. Intestinal absorption of calcium and phosphates. Then we have plasma calcium ion concentration that is going to increase. If the plasma calcium concentration has increased so much, it has got a negative feedback inhibition to the parathyroid hormone. So you have less parathyroid hormone, less activation, then you have less vitamin D3, the active form, less absorption. That's the control that is taking place. So there are checkup points where you have inhibition or negative feedback mechanism at this level as well. What are the actions of vitamin D? So by now you understand the functions or the actions of vitamin D. It has several effects on the intestines, the kidneys, and the bones that increase absorption of calcium and phosphates into the extracellular fluid. Then you have these minerals that will be available for mineralization of the bone, to have strong bones, and also to control the concentration of the extracellular calcium levels and phosphates levels. Vitamin D receptors are located mainly in the nuclei of the target cells. So they are found inside the nuclei of the target cells. That's why they will increase the enzymes that are involved in transportation of the ions when you're talking of absorption, and also the proteins synthesis that are involved in translocation of the proteins. So you have cow-binding protein that will be produced within the cells. So in other way, it will have an effect on the transcription of the DNA. Vitamin D receptor has hormone binding and DNA binding domain. So it can bind to the hormone, and then it can bind to the DNA to facilitate transcription. The vitamin D receptor retinoid X receptor complex binds to the DNA and activates transcription in most instances. So transcription of DNA into messenger RNA that will go to the ribosomes for protein synthesis. And these proteins, they could be enzymes that are involved in transportation of ions, or it could be proteins that are also involved in binding to ions and transporting them. So co-binding proteins will increase enzymes, the ATPase that will break down ATP to transport calcium and phosphates against the concentration gradient will also increase. The intestinal effects of 1,25-dihydrocholecalciferol. The 1,25-dihydrocholecalciferol itself functions as a type of a hormone to promote intestinal absorption of calcium. How? It does this principally by increasing over a period of 2 days formation of calbinding and calcium binding protein. A calcium binding protein. So it's going to increase the production of calbinding, which is a calcium binding protein in the intestinal epithelium cells. So it will increase the absorption of calcium in the intestinal epithelium cells. This protein functions in the brush border of these cells to transport calcium into the cell cytoplasm. Then the calcium moves through the basolateral membrane of the cell by facilitated diffusion to go into the interstitium, then it will be absorbed by the bloodstream. The rate of calcium absorption is directly proportional to the quantity of calcium binding protein. So if you have a lot of calbinding, even the rate of absorption of calcium is going to increase. Furthermore, this protein will remain in the cells for several weeks after the 1,25-dihydrocholecalciferol has been removed from the body, thus causing a prolonged effect on calcium absorption. In as much as you remove the active form of vitamin D3, which is 1,25-dihydrocholecalciferol, you'll find that the calbinding protein that is being produced will stay within the epithelium cells for a long period of time. That will have a prolonged effect on calcium absorption, even when you don't have the active form of vitamin B12. Other effects of vitamin B12, but vitamin D3. What are the other effects of active form of vitamin D3, which is 1,25-dihydrocholecalciferol, that might have a function in promoting calcium absorption? The formation of calcium-stimulated ATPase in the brush border of the epithelium cells. So these are involved in primary active transport. Then also the production of alkaline phosphatase in the epithelium cells. That will also enhance absorption of phosphates. Phosphate flux through the gastrointestinal epithelium is enhanced by vitamin D as well. So it's increasing calbinding to transport calcium. It's increasing calcium stimulated ATPase. It's also increasing the phosphatase in the epithelium cells. All these proteins will facilitate absorption of calcium and phosphates. The renal effect of 125-hydrocholecalciferol in the kidneys, it's going to increase calcium and phosphates reabsorption. What are the effects of vitamin D on bone and its relation to parathyroid hormone activity? The vitamin D plays important roles in both bone absorption and bone deposition. Extreme quantities of vitamin D causes bone absorption or bone resorption. The digestion of the bone is mainly activated by excessive quantities of vitamin D. So if you have a lot of vitamin D, the active form of vitamin D, that will result into bone absorption or bone resorption, so that you mobilize calcium and phosphates from the bone. But the vitamin D in smaller quantities is going to promote bone calcification. If you have vitamin D in smaller quantities, that will encourage mineralization of the bone. So it has got both functions, which are antagonizing to each other, but you just need to know that this is affected by the concentration of the active form of vitamin D. Excessive amount of vitamin D, you have more bone absorption or digestion. If you have less amount of vitamin D, then you are going to have mineralization of the bone to give you the strong bones. That's why you need the vitamin D. This is a table that is summarizing everything that we've discussed so far with regard to the parathyroid hormone. So let's look at this chart. If you have a decrease in plasma calcium, which is a hypocalcemia, that in itself is a stimulus to the production and secretion of parathyroid hormone. You know to say that the calcium sensitive receptors, they won't be activated more. There will be less of activation of vitamin phospholipase C. There will be less mobilization of inositol triphosphate or the conversion of phosphatidylinositol bisphosphate into IP3 and DAG. So less of IP3, it means you're not going to mobilize more of calcium from the endoplasmic reticulum. Less calcium, that will increase the secretion now of parathyroid hormone. It's the opposite. If you have less calcium in the cells, in the intracellular of these cells, especially the chief cells, then you have more secretion of parathyroid hormone. If the concentration of calcium is increasing, it will inhibit the secretion of parathyroid hormone. So you need to understand the two mechanisms. So here you have more secretion of parathyroid hormones. There will be an increase in plasma parathyroid hormone, of course, that will be transported to the kidneys and then to the bones. In the kidneys, what is the function of the parathyroid hormone? It will cause an increase in calcium reabsorption from the bones and also an increase in phosphates reabsorption. But here we're interested in the calcium. Then it will cause activation of vitamin D. The 25-hydrocholecalciferol will be converted into 1,25-dihydrocholecalciferol formation. This will cause an increase in the plasma level of 125-hydrocholecalciferol that will go to the intestines to increase absorption of calcium by increasing calbinding production, by increasing calcium phosphatase, calcium ATPase or calcium stimulated ATPase that are required in the intestine for absorption, then also increasing phosphatase. All that will increase the calcium absorption in the intestines. On the other hand, if you are reabsorbing a lot of calcium in the kidneys, then you are reducing the urinary excretion of calcium. So what will be excreted in the urine will be reduced because much of the calcium is being absorbed or reabsorbed into the body. That will restore the plasma calcium concentration towards a normal range. So there is restoration of plasma calcium towards the normal range. If it goes into the normal range, if you have an increase in calcium, it will be inhibitory to this pathway. So you have less release of parathyroid hormone, less activation of vitamin D, and you know what will happen. In the bone tissue, the parathyroid hormone will cause an increase in bone resorption. Why? The parathyroid hormone will go and bind to osteoblasts, releasing the osteoproteogenin ligand that will go and bind to pre-osteoclasts, activating them into mature osteoclasts that will release the the citric acid and lactic acid, and then it will also release enzymes that will cause digestion and absorption, and also resorption of the bone. You are increasing mobilization of calcium and phosphorus from the bone. You have an increase in the release of calcium into the plasma, then that will result into restoration of plasma calcium towards the normal range. Calcitonin is antagonistic to that of parathyroid hormone, so it's synthesized and secreted by the parafollicular cells or the thyroid gland. So it's not produced by parathyroid gland, it's actually produced by the thyroid gland, because within the thyroid gland, adjacent to the follicular cells, we have parafollicular cells that are producing calcitonin. Its secretion is stimulated by an increase in serum calcium levels. So if you have a lot of calcium, you need calcitonin that will have antagonistic function to that of parathyroid hormone, PTH. It will act primarily to inhibit bone resorption. It can be used to treat hypercalcemia. So it's going to inhibit bone resorption. You are not mobilizing calcium from the bone tissue, so the calcium levels will start reducing. Then it can of course be used to treat hypercalcemia. So if you have hypercalcemia, you can be given calcitonin to inhibit mobilization of calcium from the bone tissue. Then you have excretion of calcium by the kidneys. Then you find that the concentration of calcium goes back to the normal range, acceptable range. This diagram here is summarizing all the hormones that will have an effect on calcium metabolism. The summary of hormones that regulate calcium. So we have the number of hormones: parathyroid hormone, vitamin D, the active form of vitamin D, which is 1,25-dihydrocalciferol, and calcitonin. So it's just a summary of what we've already discussed. What is the stimulus for secretion of this hormone? The stimulus for parathyroid hormone is a decrease in the serum calcium concentration. If there is a decrease in the serum calcium concentration, parathyroid hormone will be secreted. What is the action of parathyroid hormone on the bone, the kidney, and intestine? On the bone, it will increase bone resorption to mobilize calcium and phosphates from the bone. On the kidneys, it's going to reduce phosphates reabsorption via increasing the urinary cyclic AMP. So you find that the reabsorption of phosphates is reduced by the parathyroid hormone. It's inhibited by the parathyroid hormone. It's also going to cause an increase in calcium reabsorption. On the other hand, it's causing an increase in calcium reabsorption in the kidneys. To the GIT in the intestine, is going to increase calcium absorption via the activation of vitamin D. So because it's activating vitamin D, you know to say that the active form of vitamin D is going to increase the cal binding, the calcium stimulated ATPase and phosphatase. So there will be an increase in absorption of calcium and phosphates. What is the overall effect of parathyroid hormone? Is going to cause an increase in calcium levels because you are absorbing it in the GIT, you are mobilizing it from the bone tissue, then you are also reabsorbing it in the kidneys. So the overall serum calcium is going to increase, but the serum phosphate levels are going to reduce. Why? Is because the parathyroid hormone is inhibiting the reabsorption of phosphates. Hence, the serum phosphate levels are going to reduce because much of these phosphates will be excreted in the urine, which makes sense. The effect of vitamin D, the active form of vitamin D. What is the stimulus for secretion of vitamin D or the activation of vitamin D? A decrease in the serum concentration of calcium will activate vitamin D, because we know to say parathyroid hormone that is increasing here can also activate the vitamin D. An increase in parathyroid hormone will also increase the presence of active form of vitamin D. The decrease in the serum phosphates will also increase the secretion or the active form of vitamin D. What is the function or the action of vitamin D on the bone, kidney, and intestines? On the bone, it will cause bone resorption. You're mobilizing phosphates and calcium from the bone tissue. In the kidneys, it will increase reabsorption of both phosphates and calcium. So you can see there's an increase in the reabsorption of both phosphates and calcium. Both phosphates and calcium is increasing. In the intestines, it's going to increase the absorption of calcium and phosphates. So you can see that via vitamin D, the activation of vitamin D. So you know to say it will increase cow-binding protein. The cow-binding protein is the one that is also facilitating absorption of calcium. Then it will increase alkaline phosphatase enzymes that are involved in absorption of phosphates. What is the overall effect on calcium and phosphates? The serum calcium levels is going to increase. The phosphate levels is also going to increase, because now the vitamin D is not inhibiting reabsorption of phosphates, it's actually increasing the reabsorption of phosphates. So the vitamin D will increase both phosphates and calcium. That's why it will provide these minerals to cause mineralization of the bone. In the extracellular fluid compartment, it will increase the concentration of calcium and phosphates. Calcitonin, what is the stimulus for its secretion? Is an increase in the serum calcium levels. The action is mainly on the bone, is going to reduce or inhibit bone resorption. You're not mobilizing calcium, you're not mobilizing phosphates from the bones, then the overall effect, it will decrease the serum calcium levels because it's not being mobilized from the bone. So you find that the calcium levels is going to decrease. So it's decreasing the calcium levels in the serum. That's why it can be used to treat hypercalcemia. If you have hypercalcemia, you can give to that patient calcitonin, and that calcitonin will reduce the serum calcium level by inhibiting bone resorption. Coming to the end of this lecture, let's discuss the abnormalities of parathyroid secretion. What are the abnormalities of parathyroid secretion? Starting with hyperparathyroidism. From the name itself, it means that there is excessive activity of the parathyroid gland is overproducing the parathyroid hormone. The primary hyperparathyroidism is an abnormality of the parathyroid gland associated with inappropriate excess parathyroid secretion, which can be due to a tumor. Maybe a tumor affecting the parathyroid gland. Then those chief cells are producing a lot of parathyroid hormone. It is characterized by an increase in the serum calcium levels, which is called hypercalcemia, and hypercalcemia is going to depress the nervous system. So you have depression of the nervous system that can also cause muscle weakness. There will be decrease in serum phosphates levels, hypophosphatemia. Why? It's because we said parathyroid hormone is inhibiting reabsorption of phosphates in the kidneys. So the serum phosphates levels is going to decrease. There will be an increase in the urinary phosphates excretion, which explains the second point there. Of course, if you're not reabsorbing much of it, then much of it is being excreted in the urine. So there will be an increase in the urinary phosphates excretion. Then you have an increase in bone resorption. You are mobilizing phosphates and calcium from the bone because you have excessive amount of parathyroid hormone. What will be the clinical signs? The clinical manifestations of hyperthyroidism will include depression of the central and peripheral nervous system. So there will be less firing of action potentials, because you know to say there will be less influx of sodium, and that will cause depression of the central and peripheral nervous system. There will be muscle weakness, because for muscle to contract, they need stimulation by action potentials. If you have less action potentials, there will be less muscle activity. Constipation, of course, for you to have motility in the small intestines, you need motility or you need contraction of smooth muscle cells. So if there are less action potentials delivered to the GIT, there will be less motility. That will bring about issues to do with constipation. Abdominal pain, if you're constipating, of course, you're going to have abdominal pain because some of the material that is causing constipation there. They can be irritating the pain receptors in the GIT. So you are going to have abdominal pain, peptic ulcers, lack of appetite. So because there's constipation, of course, you can have peptic ulcers also, and also lack of appetite. You don't want to eat when you have abdominal pain. Depressed relaxation of the heart during diastole. So that can also inhibit the function of the heart because there are less action potentials that are initiated there. The secondary hyperthyroidism, secondary hyperparathyroidism, secondary hyperparathyroidism. High levels of parathyroid hormone occur as a compensation for hypocalcemia rather than as a primary abnormality of the parathyroid gland. So here now, the hyperparathyroidism is secondary to another condition, in this case hypocalcemia. You know, to say hypocalcemia will overstimulate the chief cells to release a lot of parathyroid hormone. The parathyroid hormone is not just being, it's not like the chief cells are just overproducing the parathyroid hormone, but they are being overstimulated because of the hypocalcemia. So this hyperparathyroidism is secondary to hypocalcemia, hence the name secondary hyperparathyroidism. This can be caused by vitamin D deficiency or chronic renal disease. So in case of chronic renal disease or vitamin D deficiency, you can have secondary hyperparathyroidism because the body is sensing less amount of active form of vitamin D. The body will be forced to produce a lot of parathyroid hormone to go and activate the enzyme that will add another hydroxyl group so that you convert 25 hydrocholecalciferol into 1,25 dihydrocholecalciferol. So you find that this is another form of secondary hyperparathyroidism because you are lacking vitamin D3 and you are also maybe you're having chronic renal disease that is also affecting the enzymes that are supposed to convert the vitamin D. So in both cases, you have excessive production of parathyroid hormone that is secondary to what is happening in the body. The opposite is called hypoparathyroidism. Hypo, it means the parathyroid gland, the chief cells are producing less of parathyroid hormone, or maybe the stimulus is not strong enough to stimulate those cells to produce a lot of parathyroid hormone. Most commonly as a result of thyroid surgery, or it can be congenital. So you are born with this condition, or sometimes due to thyroid surgery. Remember, when you have hypothyroidism or hyperthyroidism, there is an increase in the size of the follicular cells, or the thyroid gland is going to increase in size. You have a goiter. So one of the treatment for the goiter is a surgical removal of the excessive amount of this tissue. So remember, the parathyroid glands, they are located on the posterior aspect of the thyroid gland. So as you're doing a surgery to remove the thyroid gland, you can also remove the parathyroid gland accidentally. So you find that when you're doing a surgery on the thyroid gland, you can damage, or you can also remove the parathyroid gland because they are very small, just behind the parathyroid gland itself. Just behind the thyroid gland. So as you are doing surgery on the thyroid gland, then you can also remove the parathyroid glands, and then you end up with hypoparathyroidism because there will be nothing to produce the parathyroid hormone. It is characterized by the following. There will be a decrease in the serum calcium levels, of course, hypocalcemia, because you don't have parathyroid hormone to control the concentration of calcium. So you're not absorbing much of the calcium, you're not mobilizing calcium from the bone, you're also not causing reabsorption of calcium in the kidneys. So there will be a decrease in the serum calcium, hypocalcemia, and you're going to have muscle tetany. Spasms of laryngeal muscles causes death. So the larynx here, you have muscles, those are laryngeal muscles. Because now you have hypocalcemia, we said hypocalcemia causes hyperexcitability of peripheral and the central nervous system. So if you have misfiring of action potentials, can cause contraction of the laryngeal muscles, squeezing the trachea, and then collapsing the airways. So you find that you can die because you suffocate. The larynx is contracting and then is closing the airways. So such spasms can cause death, tetany of laryngeal muscles because of hypocalcemia. An increase in the serum phosphate levels, because now there is nothing that is inhibiting the reabsorption of phosphates. You are going to have an increase in the concentration of phosphates, which is called hyperphosphatemia, as opposed to hypophosphatemia if you have excessive amount of parathyroid hormone. So here you're going to have hyperphosphatemia. Then there will be a decrease in the urinary phosphates excretion, because much of the phosphates is being reabsorbed in the kidneys, which makes sense. So you know, to say you're going to have the effect of hypocalcemia, an increase in the excitability of the central and peripheral nervous system, nasospasms, and everything that is associated with that, and all the clinical signs that is associated with an increase in phosphate levels, hyperphosphatemia. And when you check in the urine, you will have less phosphates concentrations there because much of it is being absorbed. Okay, so we are done with this lecture 6.